understanding the patellofemoral joint or the kneecap and how it can become unstable. So I know, Dr. Shubin Stein, this is your area. You eat, drink, and sleep this.
You're
So.
talking my language. So the patella or the kneecap and the patellofemoral joint, it's one part of the knee. The knee, I always like to talk about the knee as a 3-bedroom apartment with all the doors open. So they all communicate. You can sit in one room and shout to another. They're all communicating. So if you get a knee injection, people always wonder if you're injecting it here. It goes everywhere. The 3 parts of the knee are just determinations based on function. So it's like having a dining room and a bedroom. They serve different functions. The 2 parts of the knee that you stand and walk on, which are the medial, the inside, and the lateral, are a meeting or a mating of the thigh bone, the femur, and the tibia, which is the shin bone. And they're each a ball and socket. So it's a ball and socket on the inside and a ball and socket on the outside. And I call those like your Jack and Jill bedrooms, right? Like they communicate through the notch, which is, the thing that ties the medial and the lateral compartment, but they look very similar and they function in similar ways. They are meant for loading when you're standing, when you're running, when you're jumping. But the other compartment, which is the patellofemoral, the 3rd bedroom, the patellofemoral compartment, is really unique and different. It is a ball and socket, but it's really more of like a ball on a track. And the groove, which is the end of the thigh bone called the femur, there's a groove called the trochlea that the kneecap has to run in. Yes, I like the knuckle analogy, yes. But the balance there is critical because in the tibia and the femur and the rest of the knee, you have the ACL and the PCL that we just talked about and the collateral ligaments that all stabilize that construct. That is an intrinsically stable portion of the knee. Whereas the patella is what we call a sesamoid bone. It is free floating in between a lot of tendons and ligaments, but it doesn't have the tight tethers that the rest of the knee does. And so that patella can track in the groove, which it should, or it can maltrack or track abnormally within the groove. And that's where we start to see some problems, especially if the groove or the patella, most commonly the groove, is not shaped normally, which we see as just a way that certain people grow. It's genetically how your thigh bone grew, where the groove wasn't shaped well. And that dictates a lot of people who have pain or cartilage damage or even arthritis. It also dictates patients whose kneecaps don't track well and can be susceptible to instability, where the kneecap can actually jump off its track. Think of a train on a train track. It can come off the track and then have to be put back in. It's actually the 2nd most common in athletic injury. So when you see somebody on a soccer pitch or on a basketball court who has a traumatic injury where they fall to the ground, non-contact pivoting injury, ACL is number 1, patellar dislocation is number 2. So it is common, it's just not nearly as common as the ACL.
Are patella problems, including instability, more common in women?
So I think they are for a specific subset of patients. And so we talk about risk factors for patellar instability, and a lot of them focus on, like Dr. Shubin Stein was saying, on the how your bones were shaped. Particularly, some of the risk factors include how the groove or trochlea is shaped, where the tibial tubercle, which is this prominence of bone on the top of your shin bone, where that is located. What that does is there's an angle of where the thigh bone meets the kneecap meets the shin bone. And if that angle is towards the outside, your kneecap's going to be pulled to the outside with any activity that you do, particularly a pivoting, twisting injury. The kneecap's going to want to jump out of its track. And so there's some bony anatomy that can lead to risk factors for patellar instability. How high the kneecap sits. So the kneecap usually sits in the center of the groove, but some patients, the kneecap sits higher, which again, it's sitting outside the groove. The kneecap becomes stable when it's in its bony compartment. When it's sitting too high, the bone's not there to keep it on its track. And again, that can move it over. We've mentioned ligamentous laxity a bunch of times. So people who are loose, again, the kneecap, like Dr. Shubin Stein was mentioning, doesn't have things that keep it in its home very well. And so if you're loose, kneecap can move all over the place. And again, that can cause it to leave its track. And the way that we stand. So women sometimes stand in more valgus or more knock-kneed. And again, that's going to make the angle of the kneecap more pulled towards the outside. And that can also lead you to the kneecap jumping out of its track. And women also have rotational deformities, meaning the thigh bone is rotated differently, which can also lead to the kneecap not leaving in its track anatomically. So all those risk factors have been shown to increase the risk of patellar instability. And women, we are anatomically made different than men, and we have a higher rate of those risk factors. But men can also have them, but women do have a higher proportion of those risk factors, both bony and ligamentous.
And I would just add that for first time dislocations, because we do try to classify dislocators, people who dislocate or have patellas that or kneecaps that jump out of the groove, we call those patella dislocations, and we call the group that has them patella dislocators. There are first time dislocators, which are a subset that we look at differently than patients who've had more than one. And more than one could be 2, it could be 20. We call that group recurrent dislocators, or recurrent dislocations is what they're having. And we treat them differently because we consider them differently. And the first time group tends to be a much more equal proportion of women to men, almost 50-50, a little bit more women, but not much. Whereas in the recurrent group, 70% or more are female compared to males. And exactly for the reasons that Dr. Q mentioned.
And I think from a physical therapy standpoint, you mentioned the train. We also think about the track, right? Is it something that's happening? We try and look a little bit more proximal, meaning we look at the hip and look at the core. We look below at the foot and ankle. And is the track an issue, or is it really local to the kneecap? And in all of these, we talk about quadricep, strengthening, and I think that's really important. And I think a risk factor for women for both ACL injuries and kneecap problems is maybe the undertraining. As boys reach puberty, they tend to start weight training, where women and young girls don't do that. And so I think having that foundation of strength is really, really important.
Yeah, 100%. And as we said before, a lot of these are growing athletes. And so strengthening in a growing athlete is really hard, because as you're getting stronger, you're expanding over a larger skeleton. And so the being able to perceive that strength is harder. And so these athletes, and one of the things that we should mention is, even when we do surgery in open growth plate kids, and that means young kids whose growth plates are still growing, they take longer to rehab. They take longer to go back to an ACL. It's not 9 months for open growth plates, and it's not 9 months after the MPFL. And I've been waiting to say MPFL this entire time because I wanted to mention it. But the MPFL, which is the medial patellofemoral ligament, which runs from the inside of your patella, which is your kneecap, to the femur, which is the thigh bone, that's like the ACL of the patella. It is the ligament that is talked about the most commonly. It is the gold standard as far as surgery goes to reconstruct, because it is torn in 98+% of patients who have an acute dislocation. So the very first time you dislocate your patella, that's the ligament that has to tear. It's like a leash on a dog. If that dog is going to get across the street, someplace the leash has to break. And so that's the ligament we talk about reconstructing, just like we talk about the ACL.
I think going into treatment, like Dr. Shubin Stein mentioned, MPFL reconstruction, the studies obviously look at repair as an option, but we know the studies have not shown good outcomes from repair. So that's not really performed anymore for treatment of patellar instability, but reconstruction is the most common procedure done for patellar instability. And you can use your own tissue or donor tissue, and the studies show equivalent outcomes for those. So I think those are both good graft options. Again, a discussion with the patient on risks and benefits of using a donor or your own tissue. And then addressing the bony underlying issues that is really we don't really know. So I think bony issues can be addressed for certain patients who meet higher measurements, higher criteria. But I will shout out Dr. Shubin Stein and her Jupiter study. So she is looking at patients who a randomized controlled trial, multi-center, that means multiple hospitals across the country, are donating patients to her study looking at treatment of patellar instability. We know that patients, some of them meet criteria for surgery. The recurrent dislocators do need surgery to address their symptoms, but which first-time dislocator needs a procedure? Currently, we do it for patients who have a cartilage injury, which usually happens when a piece of cartilage gets knocked off and it floats around the knee. Mm-hmm. That needs to be addressed surgically at the first time. But if you dislocate once, your kneecap goes back in, your MRI doesn't show any cartilage injuries, who meets criteria to prevent a future dislocation? And Dr. Shubin Stein is doing excellent work to identify those patients, and also identify which patients need their underlying bony changes addressed to prevent future failure of an MPFL reconstruction. I think we have some criteria, some measurements of the bones that we can say, yes, you would need a bony procedure, which does change your recovery rehabilitation. We can talk about that later. But Dr. Shubin Stein is doing some excellent work with her Jupiter study on identifying which subset of patients we need to treat surgically and how.
Thanks very much.
Nice.
It's a study that's near and dear to my heart. It's my baby. And I think it really is something that we need better information to be able to give parents and patients more information, because I think right now we know a lot more than we did 10 years ago. I will say when I trained 20 plus years ago, we didn't even have an MPFL reconstruction. All we would do is do what's called an imbrication. We would bunch up the extra loose tissue on the inside of the knee, which is non-anatomic, intended to stretch out. And so these patients were at higher risk. And we also had bony surgeries at that point, which we still do today, which are amazing surgeries where we kind of reshift the bones back to where they were supposed to be. It's called a realignment surgery, taking that attachment of the patellar tendon that Dr. Q talked about, called the tibial tubercle, and shifting that back into the middle of the tibia so that it's in line with the groove, so it changes that vector that Dr. Q talked about. We can also cut the either the thigh bone at the end of the thigh bone, called a distal femoral osteotomy, and that can be used to treat patients who have excessive hip rotation, which can contribute to patellar instability. And it can also be the same operation can be used to treat somebody who has knock knees or excessive valgus, which is what we call that. So there's lots of other operations that we can do, but they have bigger consequences and bigger risks. Obviously, we're cutting bone. The return to sport time is significantly longer, and we want to know when we should do those. We don't want to miss doing them because they are critical, and they're a critical part of our toolbox in terms of how we manage these patients, but we also don't want to do them if they're not necessary. And if we can get patients back with a simple ligament reconstruction, return to sport time, as opposed to an ACL, which is about 9 months, given that their quality of movement is good. In MPFL, we're talking around 5 months. Again, the same criteria, they need to move well before they get back to sport, but the risk of re-tear for an MPFL is significantly lower than it is for an ACL. And so we have less stringent criteria. As long as the patient is moving well and able to get back and they have good quad function, they can get back in about 5 months. And so again, we want to be really mindful of doing the minimal amount of surgery necessary to keep that patient stable, but also get them back to sport with as low a risk profile as possible.
I think it's really important to say, you speak about these procedures so matter-of-factly, and I think the key here is to understand when you are choosing a surgeon that you choose somebody who does a lot of these. And I see a lot of Dr. Shubin Stein's patients, and they have come from other places where physicians have recommended to go to a specialist who does this. So I think that's really, really important. The indication who was right for the surgery. And I think from two things I want to touch on from a patella standpoint, which is different than an ACL, is the potential chronicity, or how long they have lived with this problem, because they have seen perhaps a local physician, their primary care physician, who didn't recognize that it was patella instability. And one of our therapists here, John Kavanaugh, talks about as long as you haven't been you, there's a certain ratio of time that how long it takes you to become you again. And I think as with these patella issues, you almost, if it happens from a young age, you almost never became you. You never developed this baseline quad strength, as opposed to a person who has an ACL injury at 25 years old, where they have a baseline of strength. So the chronicity is really, really an issue, and the expectation for the patient, and as well as the secondary and the consequences that occur from living with this for a long period of time. They develop these secondary issues that you have to kind of tease through to get to the real problem. So it's not always an easy fix, and setting expectations for the patient is so important.
I think that's such a great point, and I would say that there's a huge gray area, but there's two specific populations that we're talking about. We're
Right.
talking about the athletes who did become athletes because they
Right.
didn't dislocate until they were 14 or 15 or 16. And they are recognized quickly because it takes them out of their sport. And so we either fix them after their first dislocation if they knock a fragment off, as Dr. Q was talking about, or very quickly after their second episode, whether it's a slip or a full dislocation, they get fixed. And as you said, and John Kavanaugh says, they've only been living with that problem for a short period of time, and they know who they are. They are an athlete, or they were a lacrosse player or a soccer player, and they can get back to that. There's a different population. It's
Yeah.
the population that started dislocating when they were 9 or 10. And so they stopped playing baseball and they stopped playing tennis and they stopped being an athlete. And as you said, it's not for them, it's not getting back to sport, it's starting sports,
Right.
because they never got back into they never got into them because their knee wouldn't let them. That patient population also tends much more to have it on both knees, right? And that's something that's very different than ACLs, which can occur on both knees, but more commonly we see it in one knee throughout their lifetime. And in patellar instability, about 50%, if not a little bit more, tend to have it in both knees, especially if it starts very young.
And looking at a recent study that we did here at our institution, looking at these patient populations, like you mentioned, the first time dislocator, second time dislocator, or the recurrent dislocator, we looked at their surgical procedures, the amount of extra procedures that were done, as well as their return to sport. And so we saw that patients who had multiple dislocations, more than 2, 3, had a higher number of cartilage procedures performed. So we had to address underlying cartilage damage in somebody who's 14, 15, 16. The kneecap can only take, it has the thickest cartilage in the body, but it can only take so much
Right.
trauma sliding over before the cartilage starts to say, excuse me, hello, I need some assistance here. And then those patients who either have both knees or have multiple dislocations tend to have more of the bony factors of explaining why they have patellar instability. So we have to address those too, which, like Dr. Shubin Stein said, is a larger surgery, larger recovery. And so we found in our study that the patients who have these multiple dislocations or have the bony procedures do take longer to return to sport. And I think a lot of that is, like you were mentioning, they may have tried to go back to sport and they can't. And so their brain associates sport with a dislocation. And so that again, going back to the kinesiophobia, they've had so many injuries, so many insults to that knee. Going back to soccer might seem, okay, great, my knee feels stable, but is it going to happen again?
Mhm.
I had this big surgery, I did my recovery, my knee feels great, but what is it going to happen again? Because patellar instability is not an atraumatic experience. It's very painful for patients, and it's a scary thing that can happen. And I think kinesiophobia is something that really needs to be looked at, both for the first time, second time dislocator. It's still a traumatic event, but multiple dislocations, I think, really sits in your brain and really can impact your return to sport or starting a sport if you haven't been able to as a child.
Absolutely. I mean, yeah, there's a high level of anxiety in these patients who have experienced multiple dislocations. And I think a point to bring up when we're talking about returning to sport, everybody thinks about it at a later phase. What I tell my patients is return to sport starts day one. When you're doing that quad set, that boring quad set, if you can't do it, then you can't do a step down and you can't do a single leg squat, et cetera, et cetera. So that beginning phase is so important.
I'll also go back because I wanted to touch on one thing that Dr. Q mentioned before, which is the cartilage injury. I think one of the things that we don't realize always when we're talking about ACL patients and patellar instability patients is these are very young patients with significant traumatic injuries to their knee. And what we know from the large multi-center studies in ACL world is that the outcome of how you do from your ACL reconstruction actually doesn't have to do with your ACL reconstruction. It has more to do with the status of your cartilage and your meniscus at the time of your surgery. So if you have an ACL reconstruction with hamstring and patellar tendon, and we talk so much about grafts, really the thing that's going to make the biggest difference in how you do long term with that operation is, was your cartilage damaged at the time of the surgery? Did we have to put cartilage back because it was damaged so significantly? Was your meniscus torn? Did we have to take a piece of your meniscus out, which is the far less good operation, or could we repair it, and did that repair take and heal? Because that's what makes the difference in terms of how you do long term. Much less important is the graft, because ACLs do really well as a group as far as how the ACL itself heals. And then the other side of that is the patella dislocators. We let them dislocate more than once oftentimes. And so that's 2 and sometimes 20 very significant traumatic injuries to the knee. And these are patients who are young, 15, 16, 17-year-olds. And by the time I get to their knee, unfortunately, I see tremendous amounts of cartilage injury. I'm looking at a patella that looks like it's 60 in a 16-year-old. And that's devastating, because I know that no matter what I do to stabilize that knee, the outcome of that knee is dependent on how the cartilage does, and that's really important. So getting to these patients earlier. I don't want to see patients who've dislocated even 4 times. After the second time, that's when we indicate them to have a stabilization, or so we can make their knee stable so it will stop dislocating.
And just to clarify, so the meniscus is the cushion, and the cartilage, because you may also hear people say, well, I tore my cartilage, and use meniscus and cartilage synonymously. The cartilage that we're talking about is the lining of the bone. So if you think about ligaments are meant to protect the meniscus, and the meniscus is meant to protect the cartilage. And from a physical therapy standpoint, I'll add that muscles are there to protect, the ligaments, on top of that.
That's a great point.
And I think it even speaks to rehab, the absorption of forces and decelerating. And if a patient doesn't have adequate strength and they can't absorb forces and decelerate, the muscles then don't absorb the forces. The joint and the cartilage absorb the forces. So I think, in my opinion, from a physical therapy standpoint, we are also responsible for perhaps the development of arthritis later on if we don't rehab appropriately and send them back too soon.
And I think that kind of loops us right around to what we started with, which is the concept of prevention, which is really how we should kind of think about finishing this up, which is that what we'd really rather do than doing all the surgery on young patients for ACLs and for patella dislocations is we'd rather prevent the injuries to begin with. And how to do that is exactly what you just said, which is to keep our young athletes, young women, strong, and have the right movement pattern so they have the correct muscle balance so that they can move from the hips and from the knees in a way that protects their joints and protects these ligaments.
Yeah, I think something that kind of adding on to that is that remaining strong, I think, is key. So a lot of women think that strength training may not be for them. They don't want to bulk up, but I think women, it's very hard to be bulky to the point that you are not happy with your physique. I think strength training that's newly being popular among women. I think it's a very, very important factor in our active lifestyle. Patients, even if you aren't strong enough, you want to walk 5-10 miles a day, you're going to have knee pain. That's a lot of force on the knee, particularly all the hills here in New York City or wherever you live. I think that puts a lot of pressure across the knee, particularly the patellofemoral or kneecap joint. So strength training, I think, is key for anybody who wants to remain active, whether it's walking, running, biking, playing any sports. I think remaining strong is key. So don't be afraid of the dumbbells or the squat rack at your gym. That's really the basis for any active person is strength training in a controlled manner to get you to whatever lifestyle you want to lead.
Yeah, I think, do you have the strength to perform the movement? Do you have the mobility, the range of motion, the flexibility to support the movement? And I think too often people play sports to get in shape as opposed to getting in shape to play the sport. So I think that may be a good way to close out. Thank you so much for joining our webinar. I hope you enjoyed it as much as I did, and it was great sitting with the two of you and learning from you as I do every day.
Ditto.
Yeah, thank you so much.